Hi, welcome to POC Nurse. My name is Gozi, and in this video we're going to talk about mechanical ventilation for the respiratory section of the CCRN exam. So mechanical ventilation is a form of oxygen delivery. It's usually used in the critically ill patients to sustain life emergently or in acute situations. So when do patients generally get mechanically ventilated? I came up with 4 reasons. 1, when they can't ventilate, meaning they cannot move air in and out of their lungs. 2, when they can't oxygenate, meaning that they cannot adequately exchange gas at the alveoli capillary level. 3, they cannot protect their airways. And 4, their airways obstructed or at risk of becoming obstructed. When we talk about an inability to ventilate, a patient may not be able to ventilate if they are in respiratory depression. So let's say the patient that goes in for a procedure, for example, a CABG, they get all this anesthesia, they're not going to be able to ventilate on their own. So that kind of patients would require mechanical ventilation, or a patient that has overdosed on opiates and their respiratory drive has been diminished will probably require mechanical ventilation emergently or acutely. Secondly, for the patient who cannot oxygenate, meaning they cannot exchange gas adequately at the level of the alveoli and the capillaries, we could think about the patient in ARDS. So in ARDS, you have the alveoli filled with fluid, collapsed. Patients like that are unable to adequately exchange gas at the level of the alveoli and the capillaries. So these patients would require mechanical ventilation to help with oxygenation. The patient that cannot protect their airway are patients like, the patients that are neurologically impaired. They have a mouthful of fluid. They don't know to spit it out. They don't know to swallow it. They could inhale it into their airways, or they're just unaware of what's going on around them. It might be a trauma patient, but for whatever reason, the patient's neurological status is impaired. Their GCS is low, their level of consciousness is low, their mentation is off, they are unable to follow commands. Patients like that may require mechanical ventilation. When we talk about obstruction, the first thing that comes to mind for me is the patient with an anaphylactic reaction. Their airways swelling up, they are unable to breathe. Patients like that may require mechanical ventilation. So these are some of the reasons why some patients may get mechanically ventilated. Usually it's to acutely or emergently sustain their life, keep them alive so that they can heal and recover. For a patient to be mechanically ventilated, they have to be intubated. They have to be intubated and then connected to the mechanical ventilator. When a patient is intubated, it's important to ensure that the ET tube is in the right place, usually 3 to 5 centimeters above the carina. So to ensure that the ET tube is in the right place, what do? 4 things. At the initial phase, we can listen to the patient's lungs, auscultate both lungs to make sure that there are air sounds when we ventilate the patient through the ET tube. Secondly, we could use waveform capnography to make sure that the ET tube is in the right place. Third, we can use the CO2 detector to make sure that the ET tube is in the right place, but the best way to make sure that the ET tube is in the right place and that is 3 to 5 centimeters above the carina is to get a chest x-ray. It's also important to assess the ET tube itself. It's important to note where it is at the lip line, teeth line, or gum line, so that if it migrates into or out of the patient that you are aware. Also, it's important to get an ABG, or usually an ABG is drawn after a patient gets intubated so that the FiO2 can be titrated down. Usually when a patient is intubated, FiO2 is set at 100%, which is the amount of oxygen the patient is getting. After the first initial 20 to 30 minutes of being intubated, an ABG is drawn, and then according to what is on the ABG, the FiO2 could be titrated down or left as it is until the next ABG is drawn. Now, the endotracheal tube itself is smaller in diameter than the airways. So there's increased resistance in the ET tube. So it is a little bit more difficult to push air through it because it will be like pushing air through a straw. Also, we talked about the ET tube migrating earlier. if the ET tube migrates, it will usually go into the right lung because the right bronchi is shorter, wider, and straighter, meaning it's less angled than the left bronchi. So moving on, we're going to talk about ventilator settings. So there are usually 4 basic settings on the ventilator: your tidal volume and your respiratory rate or breath rate, your FiO2, and your PEEP, P-E-E-P, positive end expiratory pressure. So when the patient is intubated and placed on the mechanical ventilator, these 4 settings are set on the ventilator. Now, the tidal volume is pretty much the volume of oxygen that gets pushed into the patient. The respiratory rate or breath rate is how many breaths per minute the ventilator is going to give the patient per minute. The PEEP is the amount of pressure that's going to keep the alveoli open, and the FiO2 is the amount of oxygen that the patient is going to be getting. Now we're going to talk about the ventilator modes that the CCRN exam focuses on. The CCRN focuses on assist control mode, synchronized intermittent mandatory ventilation mode, that's SIMV mode. We're also going to talk about PEEP, P-E-E-P. We're going to talk about CPAP and pressure support ventilation. Now, in assist control mode, the patient receives a set tidal volume and a set respiratory rate. If the patient, so this is assist control, meaning the patient can breathe on their own and the ventilator can breathe for the patient. So if the patient stops breathing, the ventilator will continue to breathe for the patient. So in the case of assist control mode, if the patient triggers a breath, the patient will get the tidal volume that's been set on the ventilator. If the ventilator gives the breath, the ventilator will give the breath that's been set on the ventilator. So let's say in assist control mode, the ventilator is set to give 12 breaths per minute and the patient is breathing at 20 breaths per minute. All 20 breaths will get the set tidal volume on the ventilator. This is assist control mode. It can provide full ventilatory support to the patient, whether the patient is breathing or not breathing on their own. Next, we're going to talk about synchronized intermittent mandatory ventilation mode. That is the SIMV mode. SIMV mode can be used for weaning the patient off the ventilator. Why? Because the ventilator will allow the patient to trigger a breath and pull the amount of volume of air that they can pull on their own without providing any volume support. Meaning, if the ventilator is set to give the patient 12 breaths and the patient is breathing 20 breaths per minute, those 12 breaths that are mandated on the ventilator will receive a set tidal volume from the ventilator. The extra 8 breaths that's done by the patient will not receive any volume from the ventilator. The only volume the patient will get is the volume that the patient pulls himself or herself. So in this case, the patient is able to kind of breathe on their own at some point during their respiratory cycle, and that could help them potentially get off the ventilator at a certain time. Now we're going to talk about PEEP, positive end expiratory pressure. So positive end expiratory pressure is applied to the airways at the end of expiration. That's when the patient is exhaling. It increases the lung volume at the end of exhalation, and it creates more surface area for gas exchange to occur and increases the number of alveoli available for gas exchange. It's called alveolar recruitment. It can be applied to patients through artificial airways, such as the patient that's intubated, a full face mask, such as the patient that's on the CPAP machine, nasal mask, think high flow, and nasal prongs as well, high flow. In this case, PEEP helps with oxygenation because we just talked about PEEP increasing the surface area of the alveoli that's available for gas exchange. For those patients that are intubated because they are unable to oxygenate, such as the ARDS patients, we know that in ARDS, there's a refractory reaction to oxygen that's being provided to the patient. So you could give the patient 100% of oxygen via a non-rebreather, and the patient's FiO2 and the patient's O2 sat will not increase until perhaps you intubate the patient and apply a high PEEP to the alveoli. Then the patient may show a decent response to oxygen delivery. So to oxygenate a patient, we increase PEEP, we use PEEP. Now let's talk about CPAP. CPAP is continuous positive airway pressure. CPAP is PEEP that's applied to a patient that's breathing on their own. So the patient does not get any breaths from the machine. The patient does all the work of breathing by themselves, and usually you can use CPAP to wean a patient off the ventilator. The breaths that the patient is breathing on their own could be pressure supported by the ventilator. And if a patient, so for example, if you're just trying to wean the patient off the ventilator and this is their first, second try at CPAP, they may get tired after some time of being on CPAP. So that's it with CPAP. Now we're going to talk about pressure support ventilation. In pressure support ventilation, the patient receives an increase in airway pressure when they're breathing in. This is to help boost the tidal volume that they are pulling on their own. So for the patient on pressure support ventilation, they have to be breathing on their own. They have to breathe on their own because if they are, for example, sedated or paralyzed, pressure support ventilation will not come on. They have to breathe on their own for the machine to now support them with some pressure. Now the respiratory rate, tidal volume, the amount of air that they are pulling, the rate of air that they are pulling, the inspiratory time, all of this is determined by the patient's breathing effort. So the patient is doing the work of breathing on their own. So for pressure support ventilation, this is totally on the patient to breathe. So there will be no assist control mode in this case. The patient is breathing by themselves. Remember, in assist control mode, the breath could be triggered by the patient or the machine will just breathe for the patient. Pressure support ventilation is used also during weaning a patient from the ventilator, and this is done to help reduce the work of breathing by the patient, so the patient doesn't have to exert so much energy in pulling air into their lungs. So when they trigger that breath, the ventilator will help them pull breath. The ventilator doesn't pull, it pushes. It will push breath into the patient, so the patient can now easily pull that breath into their lungs. So let's do a quick recap of the ventilator settings. We set at the respiratory rate or breath rate, tidal volume, FiO2, and PEEP as set on the ventilator once the patient is placed on the ventilator. Now, depending on why the patient is being mechanically ventilated in the first place, the respiratory rate is usually manipulated as a result of what the patient's PaCO2 is. So if the patient's PaCO2 is high, if it's low, then we manipulate the patient's respiratory rate. Also, the patient's tidal volume is determined by the patient's ideal body weight, not their actual body weight. That and the medical problem that they are presenting with. Usually the patient's tidal volume is 6 to 8 milliliters per kilogram, but for the patients with ARDS, we usually try to protect the lungs and prevent trauma from the amount of volume that's pushed into the patient by giving them a lower tidal volume than usual. So for the patient with ARDS, the tidal volume they usually would get is 5 to 6 milliliters per kilogram instead of 68 milliliters per kilogram. Now the FiO2 is fraction of inspired oxygen. Like I said before, once the patient is intubated or immediately they're intubated, they usually started at an FiO2 of 100%. but this is later titrated down to the least amount of oxygen that the patient needs to maintain an acceptable O2 sat. We spoke about PEEP already as being one of the settings that's used to help in gas exchange in the patient that's mechanically ventilated. So if we want to manipulate, or if we want to make sure that the patient is oxygenating well, we would manipulate the patient's PEEP and FiO2. So now, when a patient is on the mechanical ventilator, the ventilator is basically sustaining this person's life. The ventilator may be doing all the work of breathing for the patient. The ventilator may be assisting the patient with breathing, but all in all, this ventilator is keeping the patient alive. So it's important for that ventilator to work very well. Therefore, the ventilator comes with alarms that will go off if there's any kind of interruption in delivering oxygen to the patient. So when the alarms go off, remember the alarms are for the patient's safety. So when the alarms go off, they may go off because there is high pressure in the patient or because there's low pressure in the patient. If the ventilator is beeping and giving you a message that has something to do with high pressure, a couple of things to think about as you answer the questions on your CCRN exam, and depending on the options that you get, are these. Could the patient be agitated? Could the patient be coughing? If the patient is coughing, they may be blocking the vent. Does the patient have a lot of secretions in the ET tube, and the tubing that goes from the ventilator to the ET tube? Is there water in it? Anything in the airways, such as mucus, that decreases the diameter of the airways itself, the ET tube, or the tubing that goes from the ventilator to the ET tube, could cause a high pressure alarm to go off. If the patient has a lot of secretions, it could obstruct the ventilator from delivering oxygen to the patient. Also, if there is a lot of water condensate in the tubing that goes from the ventilator to the ET tube, the high pressure alarm could go off. Also, aspiration. If the patient has inhaled things into their lungs, it could cause the high pressure alarm to go off. If any part of the tubing, the ET tube itself or the tubing that's going from the ventilator to the ET tube, if any part of that is kinked somewhere, the high pressure alarm will go off because the ventilator will not be able to deliver oxygen to the patient. The tubing could be kinked, or it could be occluded or obstructed some way, somehow. If the patient, such as your asthma patient, is having bronchospasm, their airways are tight, the ventilator is going to go off because it will require more pressure to deliver oxygen into the patient. If the patient has any kind of edema in their airway, the airways become smaller. The ventilator alarm is going to go off, signifying or signaling that there's high pressure in the system. Now, if the patient has decreasing lung compliance, such as the patient with ARDS, it will be hard to ventilate this patient. It will be hard to drive oxygen into this patient because there's increased pressure inside of the patient's lungs. The ventilator high pressure alarm will go off. If the patient has a pneumothorax, the ventilator high pressure alarm can go off. Now, these are some reasons why the ventilator could start beeping high pressure. What are some reasons why the ventilator could beep low pressure? Why could the low pressure limit alarms go off on the ventilator? If the ventilator has an interruption in the circuit anywhere, that low pressure limit alarm can go off. So let's say the tubing that goes from the ventilator to the ET tube gets disconnected, because sometimes it does happen. If it gets disconnected, the ventilator could beep a low alarm. If there's inadequate tidal volume going into the patient for whatever reason, the low pressure limit alarm could go off. If the patient has a chest tube and there's a leak in the chest tube, the low volume alarm could go off. The low pressure alarm could go off, sorry. So these are some reasons why we could get a low pressure limit alarm in the mechanically ventilated patient. Now, If the alarms are going off and you can't figure out why the alarm is going off, and you see that your patient is getting unstable, meaning that the patient's O2 sat is going down, you'd want to disconnect the patient from the ventilator and ventilate them with a bag valve device. So patients that are mechanically ventilated usually always have a bag valve device at the bedside by the ventilator. There should also be a mask in the room with the bag valve device. There should be a mask, because sometimes the ET tube itself will also get dislodged and you need to bag the patient. If this patient is heavily sedated, they might not be able to take breaths themselves. So having a mask to attach to the bag valve device will help with ventilating this patient until they get reintubated. It's important to note that for patients with ARDS requiring high PEEP, if they get disconnected from the ventilator, we could lose the alveoli that had been recruited for gas exchange and increased or more efficient ventilation, because that once the patient is disconnected, we lose that high PEEP, because now we are ventilating the patient by hand. So it may be difficult to get this patient O2 sat up just by bagging the patient. Now for the CCRN exam, it's important to know a few things about the ARDS patient and the asthma patient and mechanical ventilation of this type of patient. I believe I got questions regarding these kind of patients on my CCRN exam. I don't remember, but I remember something about plateau pressures and what to do. So we're going to talk about that now. So for your patients with ARDS, you want to employ lung protective strategies, meaning you want the plateau pressure in the patient's chest to be less than 30 centimeters of water. Now the plateau pressure signifies compliance of the lungs and the chest cavity where air goes in, basically. So if there is decreased compliance, such as the patient with ARDS, you want to push less volume of air into this patient. So you want to use low tidal volumes so that the patient's lungs don't get hurt, because if you push a lot of air into a non-elastic system, it could pop. So low tidal volumes for the patients with ARDS. Also, we want to try to maintain a normal plateau pressure of less than 30 centimeters of water. The ARDS patient also requires high PEEP, like we said before, from between 15 to 20 centimeters of water, so that they can adequately gas exchange and oxygenate. Now that is for the ARDS patient. We said low plateau pressure of less than 30 centimeters of water. It's important to know your numbers, because on the test they might not say low plateau pressure, they might give you the plateau pressure in numbers. So we want it to be less than 30 centimeters of water. Also, we want to use a low tidal volume. We talked about it before, 5 to 6 milliliters per kilogram. They might give you the patient's weight and expect you to calculate the amount of tidal volume the patient is getting. So it is 5 to 6 milliliters per kilogram for the patient with ARDS. You might be given the patient's weight, and then you'd have to calculate the tidal volume for this patient. High PEEP. PEEP is normal, like for the patient that needs minimal settings on the ventilator, they would have like 5 centimeters of water of PEEP. For the ARDS patient, we're going to give 15 to 20 centimeters of water in PEEP. Okay, this is for your CCRN exam, so it's important to memorize these numbers. Secondly, we're going to talk about the asthma patient. So for the asthma patient, we have a problem with the airways being constricted and tight. So for the asthma patient, even though the airways are tight, they can breathe in air, but they have trouble pushing out that air. It's not easy for them to get the air in, but they can get it in. But it is more difficult for them to get the air out. So there's a tendency for them to develop auto PEEP and air trap in their lungs. So because of that, For the asthma patient, we want to set the ventilator to have a short inspiratory time and a long expiratory time so that they can have adequate time to clear the airways of air. Secondly, we want to utilize a low respiratory rate so that we can maybe reduce the chance of them air trapping in their lungs. We also want to use a low tidal volume and a high peak flow rate. A high peak flow rate would help them inspire more oxygen. And we also have to monitor these patients for auto-PEEP. So the main thing with the asthmatic patient is to provide a short inspiratory time, a shorter time for them to pull in breath, and the longer time for them to get that breath out. So you may get questions on these two disease conditions, ARDS and asthma, regarding mechanical ventilation. So it's important to know this information. Now, we're going to talk about weaning a patient from mechanical ventilation. When do we wean the patient off? Well, we wean the patient off when the original reason for them being intubated has been resolved. Let's say they had OD'd on drugs, or maybe they had surgery and were sedated during the surgery. Now they are awake, they are following commands, they are alert, they can be weaned from the ventilator. Also, if their resting minute ventilation is less than 10 liters per minute, they can be weaned from the ventilator. If their spontaneous tidal volume is greater than 5 mL per kilogram, they can be weaned off. If their vital capacity is above 10 mL per kilogram of body weight, they can be weaned off. If their oxygenation is acceptable with an FiO2 of 50% or less, with ABGs, they may be able to get weaned off. Now, if you start weaning a patient off, let's say you put them on CPAP, so you can see if they can breathe on their own. If they get tachypnic with a respiratory rate of greater than 35 breaths per minute, you stop. You stop the CPAP and put them back on whatever setting they were before, where they were breathing more comfortably. If they get apneic, if their respiratory rate is less than 8 breaths per minute, you stop the spontaneous breathing trial or the weaning process. If they start to desaturate, their O2 sat is less than 88%, you stop the breathing trial. If they get into any kind of respiratory distress, they're breathing fast, they're having restractions, nasal flaring, we stop the breathing trial. If they go from following commands to not following commands, confused, agitated, there's a change in their mental status, we stop the breathing trial. If they start throwing some kind of weird arrhythmia, they get super tachycardic, they're throwing PVCs left, right, and center, or they have some kind of weird disorganized rhythm, we stop the breathing trial. If they get hypotensive acutely, we stop the breathing trial. This is the final video for the pulmonary section of the CCRN exam. I hope you find it helpful. I thank you for listening to my videos. Please like, share, and most of all subscribe, and I'll see you in the next video. Bye bye now.